These are some of the projects we worked on with our partners. I'm not going to talk about these projects. Our panelists will talk a bit more on some of these projects. And so while AI really has potential in public health, and over the past few years there have been major technological advances, we also need to appreciate that some AI products tend to fall short because they don't always align with how users think, how users behave, and how users make their health decisions. And this is the gap that AI can help us bridge. So we've identified 5 key areas where behavioral science can really make a contribution in the design of these digital health interventions. So firstly, we can use behavioral science to generate demand for these AI tools, particularly in contexts where users may not be aware of the tools or users may lack trust in the actual tools. And creating this demand then includes framing AI in familiar, relatable ways. We could also leverage some behavioral economics principles that addresses some common biases that make people not engage in AI tools. And we could also start thinking about leveraging existing platforms that people are already using, like WhatsApp, in how we create demand for these AI tools. The second key area looks at how behavioral science can improve engagement and framing. And this really focuses on how behavioral science can help AI products cut through the noise, helping users to be able to engage meaningfully and consistently. And this means that we need to train AI to recognize cognitive biases that users present in real time. It also requires framing both questions and responses in ways that really resonate with the potential users, and using attention capturing nudges to guide decision making for users as they navigate these AI tools. Thirdly, behavioral science can improve the interface and interaction design, making AI tools more intuitive, more attractive, and motivating for users. And so we really need to focus on simplicity and usability and motivation of using these tools. And sometimes this can really be achieved through removing clutter rather than adding features onto the existing tools, and really align the experience with how people actually process information. And this refers to the user-centered design in AI projects. Fourthly, AI can help identify behavioral barriers, but only if we train it in the right kinds of data. So training AI in behavior-informed data can enable the AI to predict drop-offs or disengagement in care more accurately. It can tailor support in accessible and relatable language and complement what healthcare providers would have probably missed in their practice. And finally, behavioral science can guide how AI shows up, whether it's a companion to care recipients or provide support to healthcare providers. For example, AI can be trained to pick up behavioral challenges that care recipients encounter and support healthcare providers to suggest real-time behaviorally informed strategies that address care recipients' cognitive biases. And so as the digital health technologies keep growing, we really need to consider how we incorporate user voices in how they are being designed and how we can draw and leverage behavioral science in the design of these digital tools. With that said, we will now move to our panel discussion. So we'll now move to our panel discussion for some examples and lessons learned from different projects. Let me introduce our first speaker. Ms. Sarah Morris is a Chief Product Officer at Odere, a global digital health non-profit advancing health equity through AI-powered self-care and clinical decision support solutions. A systems thinker with a mission to make technology more human. She leads product strategy, design, and research for Odere's groundbreaking multimodal AI platform. Most recently, she led the launch of Self-Care from Anywhere, a comprehensive SRH, HIV, and mental health solution delivered via WhatsApp for private empathetic support and care across Africa. So Sarah indirectly collaborated with Odere on various projects over the past few years, and most recently collaborated on the Self-Care from Anywhere project. Would you like to briefly describe what the Self-Care from Anywhere project is, how it uses AI, and really in line with our efforts to incorporate user voices in the design of these AI projects? Can you also briefly explain why it was important to conduct a contextual inquiry and a product usability study for this project?
Yes, case. And I think the one key lesson that I can draw from that that's relevant here as well is that if you don't have published data, then it's very difficult to incorporate these tools as a policy priority. So in thinking about, it's easy to say there's a gap, but how do we actually do it? And in thinking about that and thinking about developing health economic tools, I think it's useful to think about the various levels of complexity when we're dealing with digital health innovations and AI tools. There's the complexity of the products itself, right? These are often multi-component, multi-partner products with different IP considerations, but there's also the complexity of the outcomes. These products can often have very far-reaching impact, but societal gains, and are we adequately valuing those? And then there's also the causal pathway, as opposed to your normal health, other health interventions. It can often be quite easy to link a specific intervention to an outcome, but when we're thinking about AI and digital health tools, there's a lot of feedback mechanisms as well, and so thinking of as an economist, it's always important to think about causality, and that can be quite complex when it comes to digital health innovations. And so, to be able to really do economic evaluations of these tools, I think understanding the complex systems is really important, and that's where I think researchers working closely with the providers is key to sort of overcoming that barrier. I also think there's a lot of advantages in the sort of analyses. These tools by nature develop a lot of data, and so maybe there's a bigger role for data scientists when it comes to doing economic evaluations of these types of tools. And then there's also a lot of practical considerations. For anybody who's familiar with economic evaluation methodologies, you have to consider the time frame. I think with a lot of these tools, there's really high startup costs, but we expect the impact to be really long term. And so maybe the time frame that we assume here is not a 2 or 3 year project. We should be assuming a lifetime time frame, time horizon, and we sort of have to model the impact of these interventions. We also have to consider what are we comparing. There always has to be a comparator with the economic evaluation. Are we thinking that there are other digital health tools? Are we measuring this against the status quo? That's something to consider. And then something that pops up in the literature a lot is the sort of equity considerations as well. Some people are concerned about the digital divide and the fact that that could widen health inequalities. And all that being said as well, the biggest barrier to overcome is the dynamic and adaptive nature of these digital health tools. They change constantly. There are dynamic costing models associated with them, and there are steep learning curves. And so we have to consider the trade-off between digital innovation and but also formalizing this process of economic evaluation. And so I think a lot of organizations have started formalizing that. So the World Bank has a framework on how to think about the economic evaluations of these tools. The Cheers checklist has moved towards establishing the Cheers AI checklist. That's incredibly useful. And so just to summarize, I think in thinking about cost sustainability, it's really important for us as researchers to understand the anatomy of these AI tools, to be able to do thorough economic evaluation. And Sarah, if you don't mind me, you in a previous call, you actually had this really great example of the fact that sometimes we think that data costs are a big barrier to entry, but actually people, if they really like the tool, they will make a plan to use it. And if we're doing an economic evaluation, are we actually capturing that value? Are we adequately measuring all the potential benefits of these tools? So a lot of ideas, but I think we just need to get a lot of people sitting together and doing a lot of statistics. Thank you.
Common way of trying to find additional people who might be at risk of HIV. So if you come and get an HIV positive test, we would ask about your sexual network and whether we could also reach out to them and test them. That's highly stigmatizing, and particularly for men that do not like that approach. And so a softened version of that is to say, are there people in your lives that you care about, their health? Could we offer an opportunity to people that you know, your peers, your family, your partner, an opportunity to connect and support their health? And that is less stigmatizing, because and so that's what we're doing. We're trying to say, there are people you care about in your life, here's this AI tool, why don't you share it with them? And that way we have the ability to reach people's sexual networks, but we're not just calling out that those are the only people we want to talk to. Obviously, as this tool grows, there may be more functionality and opportunities for integration into mental health or TB, etc., that makes sense that the network is spread beyond just HIV positive individuals.
What are the ethical challenges that you anticipate? Because this is I see that there's a plan to integrate into like government healthcare data. So it could be problematic because this is sensitive healthcare information. So what ethical challenges do you anticipate, especially that, you know, some of the things that are going to be collected might not be legal in some places. For example, MSM was mentioned here. So in some places, somebody could get arrested for that. Mm-hmm. So what are the ethical challenges that you anticipate? Thank you.
Maybe it's something that was being said. But the first presenter said the AI is built on or informed by behavioral science insights. So my question then is, because she also spoke about the impact already that is there, how the tool is assisting in terms of whatever. So the question then that I have is, like, health intervention developers, we sometimes believe that science or literature on its own may not be the only solution. We really need, patients' experiences. I think Sean and the presenter next to him mentioned something very important, that when we develop these interventions, it's important that we don't develop something that we're not going to get fruits out of them, especially when we just focus on science and literature without targeting, because when you target, it means you know what you're responding to. So with the impact that you shared, does it mean that, because obviously those research surveys may require money that we may not have before developing? With your project, does it mean that we may not need to do needs assessment? We can rely on science as okay. So I said it's a comment that leads to a question. The second one, thank you, the health economic lens. Your last statement was, it's a long way, we need a lot of people to come on the table. And then the comment that I have is, when you were talking about economics and stuff, you spoke about developing and scaling up and all that, meaning looking at the systems part of it and policies and all that. I didn't hear much about, because I'm a community systems patient-centered care advocate, I did not hear much about how do we consider accessibility for these interventions from the client side. And I think there's also a lot of mentioning about this is not replacing the human element. We cannot run away from the fact that with the fluidity in the funding landscape, we really need these interventions. But how do we make sure that health economics lens, looking at the patient side, will it be accessible to the client in order for us to get to where we want to go? Okay.
And especially doing this in countries where these powerful tools could be misused, and will be and are. I mean, big tech companies are open sourcing these models. So just know that right now governments already all around the world are using them, probably in ways that would horrify us. And that keeps me up at night. But for our specific tool, I will say, we did a lot of, this was part of the co-design process actually. A whole lot of our time with young people initially was spent on, do they understand data privacy? What are their concerns? How could we tell them how the data is being used? Who is seeing their data in a way that they would understand? And that was actually a really big focus of our usability study. You wouldn't think so, but that was a piece we really honed in on. And so for the data, I'll say we only use versions of software where they do not use the data for training. So for example, if we're using ChatGPT, for example, to power one part of the system, because it's pretty complex on the back end, we use a paid version where they don't actually get to see that data, take it in, keep it to make the model better, which is good, right? That keeps the data. We also are POPI Act compliant, all of the data that we are storing stays resident in South Africa. Nobody sees the phone numbers. So myself, our colleagues, it is all completely masked, encrypted. Nobody gets to see those phone numbers. We have, fake names, fake IDs, and we take privacy incredibly seriously because these tools are powerful and they could be misused. And if we don't, as I will say as the digital tool maker, if we do not uphold those morals and values, we talk a lot about doing what governments want. I will not violate, we will not violate, those ethical principles. So I think we're very lucky. We're working in South Africa, Zimbabwe. The ministries have been amazing to partner with us on this journey so far. And the data, we tell people where it's used, who sees it, what they see. So, yeah.
How AI tools are being developed and designed to complement what is already happening in the healthcare system. And so these tools are not really meant to replace humans, but to complement what they are currently doing within health systems. And so these are really early days in trying to train these AI tools to be very specific, to be empathetic, like how Sarah was describing the self-care from anywhere tool. And so there's really great potential to think about what kind of data do we use to train AIs to help us with behavioral barriers and risk identification for our clients, and support providers to provide tailored care and prevention options for the clients or participants in those platforms. So it's really early days, but there's great potential in how we rethink, how we incorporate behavioral science and leverage these very important behavioral economics principles in the design of these AI projects to make them more relevant and respond to the needs of our users.
So just from a methodological point of view, when we do health economic evaluations, we usually adopt a perspective. So we can either do the costing and evaluation from the provider perspective, we can do it from the societal perspective where we look at everything, or we can adopt a patient perspective. And that's where we look at what are the specific costs for people to use this tool or any intervention. They say travel time, are there opportunity costs, are they missing out on going to work or spending time with family. That's the type of evaluations that we can do. And just, unfortunately, it is the perspective that is mostly ignored because it is so data intensive to collect. But I think it's a really good point that we shouldn't just naturally adopt the provider perspective and only look at the costs for the provider. We should consider the specific costs and effectiveness for the patients as well. Thank you.
Thank you. Maxime Engels, University of Lincoln in the UK. Thank you for the very brilliant presentation. As it was highlighted at the beginning of the session, AI intervention attract more and more funding and interest. Also, what we notice is they often benefit very privileged group, those who have access to smartphone, but also digital literacy and also network access. And a lot of community in the global south, but also in the global north, suffer from this digital exclusion. So my question is more addressed to the panel. How do we make sure that those new technology actually reduce potential access to information and care inequality and not exacerbating them? Thank you.
Hi, my name is Ben from FHI 360, and I think I have a question for Alistair or others that are using the coaching model of the chatbots. My question is, what is the unique value for clients to use these chatbots as opposed to ChatGPT that can do much of the same functions with the same sort of tone and support and linkage to available services that it can find online? And my suspicion is that maybe, because I probably wouldn't be using those coaching chatbots myself, maybe others wouldn't, that maybe clients are looking to complete practical steps in their service access or other things that would not be done on ChatGPT on another chatbot, like booking an appointment, reviewing their experience at a clinic, practical things that need to be plugged into a health system or to the health provider. So your reflections on those things.
That last question, just in 30 seconds. I mean, it is a question that gets asked. I try to start to touch on that, and I think that there are many products that are going to be built on top of these foundation models that add additional features that are relevant for a certain population. So for example, we do have reminders. We have the ability to share within the network. There will be data that gets collected that allows you to refer to local services. I think character.ai website, where you can kind of formulate a particular character and talk with that, has got millions of users, and our characters that Sean and his team and they've been working on, I think, are particularly focused on personalities and characteristics of local kind of, that are more locally relevant. So I think that those are all key reasons for why something like this should work, but I'll let the others add to that. I just briefly forgot what the first question was.
Access.
Thank you very much. Sorry about that. So this has been a question since the mHealth days, right? 2008, when the iPhone came out, it was, is this going to create a digital divide? And honestly, to me, it feels like over the last 15, 18 years, it has continued to be a problem. The two thoughts that I have on that: one, you could say something similar about brick and mortar clinics. It's like, well, people who don't have access to transport money, you are being unequitable by putting a facility down there, because how are they going to reach that? They don't have transport money. But we have to start somewhere, right? And I think that that's how I feel about this digital space, is that we have to start somewhere. If this tool turns out to be that valuable, there should be a massive international move to say that, just like water and electricity, having access to the internet or a mobile phone should be a human right.